Pneumonia is an acute or chronic inflammation of the alveoli, alveolar pneumonia, and/or the lung tissue, interstitial pneumonia. This causes swelling and increased blood flow to the affected area of the lung. The disease is typically accompanied by a buildup of fluid in the lung tissue. Depending on its extent, alveolar pneumonia is divided into lobar or focal pneumonia. Lobar pneumonia usually affects an entire lobe or segment of the lung. Focal pneumonia is called this because one or more foci of inflammation have developed within a lobe of the lung. Pneumonia can also start in the bronchi and attack the surrounding tissue, bronchopneumonia. Around 400,000 people in Germany fall ill with pneumonia every year. During periods of severe flu outbreaks, i.e., especially in winter, the number is significantly higher. The risk group includes infants and small children, as well as elderly patients over 60 years of age and people with serious chronic illnesses. They are particularly susceptible to developing pneumonia due to their immature or weakened immune systems. Pneumonia is usually caused by bacteria, less often by viruses or fungi. The disease can develop very differently depending on the patient's general state of health and the type of pathogen. Around 1 in 7 cases of pneumonia is so severe that it requires inpatient treatment. Pneumonia is the most common fatal infection in Western Europe. It ranks 5th in the national statistics on causes of death, with around 3 to 5% of patients dying from it every year. Diseases acquired in hospital, known as nosocomial pneumonia, are particularly dangerous. They are usually difficult to treat because their pathogens are resistant to many antibiotics. Causes of pneumonia? Transmission routes. The pathogens that cause pneumonia usually come from the patient's own nasopharynx or are transmitted by droplets from other patients when they speak, cough, or sneeze. The lungs normally have various defense mechanisms that are designed to prevent bacteria, viruses, or other pathogens from entering. Small cilia that are located in the mucous membrane of the respiratory tract and are constantly moving prevent dust particles from entering the lower respiratory tract and from the alveoli and settling there. If particles do reach the alveoli with the inhaled air, they are usually removed by cells of the immune system and rendered harmless. If the lungs' defense mechanisms are impaired, however, microorganisms can settle and cause inflammation. This so-called airborne infection route is by far the most common. Pneumonia can also be triggered by caustic and toxic gases, various medications, or radiation therapy. Foreign bodies that accidentally enter the respiratory tract can also lead to the development of pneumonia, aspiration pneumonia. In rare cases, pneumonia is caused by pathogens that are transmitted via the bloodstream, hematogenous infection, and washed into the lungs. Spectrum of pathogens. While in adulthood pneumonia is primarily caused by an infection with pneumococci, the bacterium Haemophilus influenzae type B is the most common pathogen in small children. In infants, however, Staphylococcus aureus is the main pathogen that causes pneumonia. In adults, Mycoplasma, Legionella, and Chlamydia pneumoniae also play a role. However, viruses, fungi, or parasites can also cause inflammation of the lungs. The spectrum of pathogens in nosocomial pneumonia, pneumonia acquired in hospital, differs significantly from so-called community-acquired diseases. The main causes of these infections are enterobacteria such as Pseudomonas aeruginosa, Klebsiella, and also Staphylococci. Many inpatients have weaker immune systems and therefore inadequate protection against pathogens. The germs in the hospital itself represent another problem, as they have often become resistant to the antibiotics commonly prescribed and are therefore difficult to treat in many cases. Pneumonia. Risk factors. Secondary pneumonia. With various underlying diseases, there is a risk of developing pneumonia. The underlying disease has already damaged the lungs, which makes it more likely that pneumonia will develop. This is then referred to as secondary pneumonia. So-called hypostatic pneumonia is the most common of all secondary pneumonias and is caused by poor ventilation and blood flow to the lower lung areas, for example, in bedridden patients. This creates ideal conditions for bacteria to settle and cause inflammation. Pneumonia can also develop in people with existing heart disease, such as left heart failure or after a heart attack. Due to the damaged heart, blood backs up into the lungs, which can lead to so-called congestive pneumonia. General risk groups. Pneumonia primarily affects people whose immune systems are not yet fully developed or are already weakened. These include, in particular, infants and small children, as well as older people over 60 years of age, but also patients with chronic heart disease, chronic bronchitis, diabetes, or severe neurological diseases. The general risk group also includes people infected with HIV, alcoholics, people who are receiving chemotherapy or radiotherapy, and patients who need artificial ventilation. The lack of coughing plays an important role in cleaning the lungs. As the immune system is weakened, the spectrum of pathogens in this group of people is expanded to include other pathogens, e.g. fungi or other so-called mycobacteria that would not normally cause pneumonia in healthy people. In addition to these general risk groups, depending on the type of pathogen, other factors often play a role in the development of pneumonia. For example, pneumonia often occurs as a complication of other illnesses such as viral flu, influenza, or measles. Pneumonia clinical picture. Pneumonia can progress very differently. This depends mainly on the general health of the patient and the type of pathogen. Classic bacterial pneumonia. The typical pneumonia caused by pneumococci usually occurs during the cold season and is primarily observed in older people or those who already have a previous illness. The illness is often preceded by an infection in the throat or pharynx. Classic pneumonia often begins with chills and a fever of over 38.5, which can often rise to 40 degrees Celsius. The patients usually appear very ill. A cough usually sets in after a short time. At first it is still dry, but after a while mucus is coughed up that is green, yellow, brown, or rust-colored. What is noticeable in those affected is that their breathing is usually shallow, strained, and rapid, tachypnea. Depending on which side of the lung is affected, breathing movement is significantly restricted. Patients often complain of chest pain, especially when breathing in, which is caused by an accompanying inflammation of the pleura. Some patients also experience shortness of breath, which is expressed by what is known as nasal flaring. Nasal flaring is a sure sign that they are suffering from shortness of breath, especially in small children. Due to the superficial and rapid breathing, the oxygen supply is no longer optimally guaranteed. The resulting lack of oxygen can occasionally be seen on the lips, nose, toenails, or fingernails, which then appear bluish to violet, cyanosis. The infection can also take a completely untypical course with a slow deterioration of the general condition. Atypical pneumonia. Atypical pneumonia is mostly caused by viruses and/or so-called mycoplasmas. In contrast to pneumococcal pneumonia, the symptoms develop much more slowly, so that the full clinical picture usually takes several days to develop. Patients are generally younger and healthier than with classic pneumonia. In atypical pneumonia, headaches and aching limbs are the main symptoms, although the general condition is generally not affected much. Chills are rare. The fever curve rises only slightly and rarely reaches values above 38.5 degrees Celsius. Those affected suffer from shortness of breath much less often than is the case with classic bacterial pneumonia. Furthermore, very few patients complain of pain related to breathing. The cough is dry and long-lasting, a so-called unproductive cough, i.e. no mucus is coughed up. In children, inflammation of the eardrum is often observed. Special forms, Legionella pneumonia, Legionnaire's disease. Legionella can be transmitted through air conditioning, showers, or baths. This is particularly the case when the water cannot be heated above 60 degrees Celsius. Older people, patients with diabetes or a weakened immune system, are particularly at risk. Less than 10% of those infected develop pneumonia with high fever, chest pains that depend on breathing, and blood in the sputum. Chlamydia pneumonia. The symptoms of chlamydia pneumonia correspond to those of atypical pneumonia. This form of pneumonia is characterized by a persistent, usually dry cough. Patients often also complain of fever and muscle pain. If the disease is not treated properly or not treated at all, it is often very long-lasting, lasting up to 3 months. The pathogens of so-called ornithosis or psittacosis also belong to the chlamydia. If there are parrots or other bird species in the patient's home, psittacosis should always be considered. Pneumonia special features in childhood? Children with pneumonia usually appear very dull, pale, and sick. They often sweat a lot. Just as in adults, the typical symptoms such as coughing, chills, rapid pulse, strained and rapid breathing, tachypnea, shortness of breath, dyspnea, and the accompanying nostrils often occur. The latter is a clear sign of severe pneumonia, especially in infants and small children. The cough is often dry, painful at first. After a few days, greenish mucus usually forms, which older children cough up, while infants swallow it and can vomit on it. Children also often experience skin retractions in the chest, abdominal pain, nausea and ear pain, middle ear, eardrum inflammation. Small children have high fevers, especially with bacterial pneumonia, while with pneumonia caused by viruses and mycoplasmas, the fever curve rarely exceeds 38.5 degrees. Pneumonia in children can also have a completely untypical course. In infants in particular, the general condition can be barely affected by a slightly elevated temperature. Sick infants and small children are usually treated as inpatients. Pneumonia is often the result of a cold, e.g. bronchitis, but it also occurs as a complication of measles or cystic fibrosis. In infants and small children, the bacteria Staphylococcus aureus, Haemophilus influenzae type B, and pneumococci are among the most common pathogens. In the first year of life, children should be protected against Haemophilus influenzae B type B with 4 vaccinations, which also immunize against other diseases. Children can be vaccinated against pneumococci from the age of 2 months. Pneumonia complications? Complications of pneumonia can occur in the lungs as well as in other organs. One of the most serious complications is respiratory insufficiency. The patient is no longer able to breathe independently and take in enough oxygen. This results in severe oxygen deficiency. Blood poisoning, sepsis, is also one of the worst complications. The pathogens are spread throughout the body, causing inflammation in many organs. Both complications absolutely require intensive medical treatment with mechanical ventilation if necessary. Any acute pneumonia can develop into a chronic inflammation with a long-term course. Such chronic pneumonia can lead to bulging of the bronchi, bronchiectasis, which can lead to recurring inflammation or even pulmonary bleeding. As a result of the inflammatory reactions, the lung tissue becomes scarred and is then less elastic. Since patients with severe pneumonia are confined to bed for a long time, thrombosis, closure of a vein by a blood clot, can occur. In the worst case, such a thrombus can be carried into the bloodstream and block a vessel in the lungs, embolism. Pneumonia can also lead to meningitis or an accumulation of pus in the brain abscess. Inflammatory changes to the heart, joints, and bones are also to be feared. Pneumonia examination methods: anamnesis and examination. At the beginning of every examination, the treating lung specialist will ask you in detail about your current symptoms, but also about previous and existing illnesses. This so-called anamnesis is therefore a first and very important guide to being able to recognize and assess possible pneumonia. In the subsequent physical examination, the doctor tries to determine possible compaction of the lung tissue, which occurs in every form of pneumonia. The focus is on listening to the lungs and heart with a stethoscope, auscultation, and also tapping the patient, percussion. The so-called vocal fremitus gives the doctor further important diagnostic information. During this examination, the patient says 99 so that the doctor can feel transmitted vibrations on the back. If the lung tissue is compacted, as is the case with pneumonia, the vibration is increased. Bronchophony offers an additional option for detecting compacted lung tissue. The doctor asks the patient to whisper 66 and listens to the lungs at the same time. Speech is transmitted much more poorly in dense tissue. Laboratory bacterial tests also provide other important information. On the one hand, it is possible to examine cough sputum under a microscope for various pathogens. On the other hand, bacteria can be grown from a patient's blood sample, creating a bacterial culture in order to gain information about the possible cause of the pneumonia. Both methods have their disadvantages. Microscopic examination is a very quick way to detect pathogens. However, there is always a risk of contamination, so it is not very reliable. In a bacterial culture, however, the pathogen can be identified and at the same time, it can be checked whether there are already so-called resistances to various antibiotics. Unfortunately, cultivation takes a long time, 2 to 3 days, so in many cases, treatment must be started before the pathogen is known exactly. Blood count. The blood count can also provide initial conclusions about the actual presence of pneumonia and its type. In bacterial pneumonia, the proportion of white blood cells, leukocytes, is usually increased, while in viral pneumonia, no significant increase in leukocytes is noticeable. In bacterial pneumonia, immature precursors are also found in the blood, which doctors refer to as a left shift. In atypical pneumonia, on the other hand, there can be an increase in lymphocytes, special white blood cells that are found in the blood, lymph, and bone marrow. X-ray. In patients who are suspected of having pneumonia or who already have clearly developed symptoms, the lungs are X-rayed. The X-ray can provide conclusions about the location and possible causes of pneumonia. Although there are very typical and specific findings for certain causes or pathogens, these can sometimes also appear quite atypical. Inflammation can be seen in the X-ray image as so-called shadows or densities, which are visible as lightening. The X-ray image can also provide clues to any underlying diseases that may have contributed to pneumonia. Antigen or antibody detection. This method is used primarily when a typical pneumonia is suspected. Urine, sputum, and/or lung tissue or rinse water taken using bronchoscopy are examined. Differential diagnosis. If pneumonia heals slowly, the differential diagnosis must include lung cancer, an inhaled foreign body, e.g. peanut, or tuberculosis. If antibiotic therapy does not improve the symptoms, inflammation caused by allergies should be ruled out at all costs. Pneumonia therapy. The treatment of pneumonia depends on its cause or the type of pathogen and the symptoms it causes. It includes both general and medicinal measures. General measures, in any case, patients with pneumonia should take it easy physically. If they have a fever, the treating lung specialist will recommend bed rest. In particularly severe cases, admission to hospital may even be necessary. This primarily affects older and immunocompromised people and small children. They quickly develop shortness of breath with a lack of oxygen, which requires additional oxygen or, in the worst case, even ventilation. Patients with pneumonia should drink a lot. This is particularly important if they are taking mucus-loosening medication. The symptoms pneumonia can also be alleviated by means of breathing exercises and regular tapping massage, tapping the chest. Medicinal therapy. In most cases, pneumonia requires medicinal treatment before the exact pathogen is known. So-called broad-spectrum antibiotics are therefore prescribed. These are drugs that are effective against many of the possible germs. As soon as the pathogen is identified, the antibiotic used up to that point may be replaced with one that is more targeted. Classic pneumonia caused by pneumococci is usually treated with penicillin. The pathogen Haemophilus influenzae type B, HIB, which is common in childhood, can be successfully combated with ampicillin or amoxicillin. Pneumonia caused by chlamydia, mycoplasma, or legionella can be treated well with so-called macrolides. Treatment with antibiotics is limited to pneumonia caused by bacteria. The course of pneumonia caused by viruses cannot actually be influenced by medication, so one restricts oneself to general measures and attempts to avoid complications. However, a so-called bacterial superinfection, additional infection with bacteria, often develops, which in turn requires the administration of antibiotics. If patients suffer from a productive cough, i.e., they produce a lot of thick mucus that is difficult to cough up, they are prescribed so-called secretolytics. These are medications that are intended to loosen and liquefy the mucus in the lungs so that it can be coughed up more easily. If, on the other hand, the cough is dry, as is usually the case with atypical pneumonia, so-called antitussives can suppress the urge to cough. It is important to know that secretolytics, antitussives, should never be taken together, as otherwise the loosened mucus cannot be coughed up and existing shortness of breath would become even worse. Pneumonia therapy. The treatment of pneumonia depends on its cause or the type of pathogen and the symptoms it causes. It includes both general and medicinal measures. General measures. In any case, patients with pneumonia should take it easy physically. If they have a fever, the treating lung specialist will recommend bed rest. In particularly severe cases, admission to hospital may even be necessary. This primarily affects older and immunocompromised people and small children. They quickly develop shortness of breath with a lack of oxygen, which requires additional oxygen or, in the worst case, even ventilation. Patients with pneumonia should drink a lot. This is particularly important if they are taking mucus-loosening medication. The symptoms of pneumonia can also be alleviated by means of breathing exercises and regular tapping massage, tapping the chest. Medicinal therapy. In most cases, pneumonia requires medicinal treatment before the exact pathogen is known. So-called broad-spectrum antibiotics are therefore prescribed. These are drugs that are effective against many of the possible germs. As soon as the pathogen is identified, the antibiotic used up to that point may be replaced with one that is more targeted. Classic pneumonia caused by pneumococci is usually treated with penicillin. The pathogen Haemophilus influenzae type B, Heb, which is common in childhood, can be successfully combated with ampicillin or amoxicillin. Pneumonia caused by chlamydia, mycoplasma, or legionella can be treated well with so-called macrolides. Treatment with antibiotics is limited to pneumonia caused by bacteria. The course of pneumonia caused by viruses cannot actually be influenced by medication, so one restricts oneself to general measures and attempts to avoid complications. However, a so-called bacterial superinfection, additional infection with bacteria, often develops, which in turn requires the administration of antibiotics. If patients suffer from a productive cough, i.e., they produce a lot of thick mucus that is difficult to cough up, they are prescribed so-called secretolytics. These are medications that are intended to loosen and liquefy the mucus in the lungs so that it can be coughed up more easily. If, on the other hand, the cough is dry, as is usually the case with atypical pneumonia, so-called antitussives can suppress the urge to cough. It is important to know that secretolytics and antitussives should never be taken together, as otherwise the loosened mucus cannot be coughed up and existing shortness of breath would become even worse. Pneumonia prognosis. The prognosis of pneumonia depends on various factors. The pathogen causing the infection, the state of the patient's immune system, and whether the correct therapy has been chosen are all crucial factors. Older people, or those with pre-existing diseases such as heart or lung disease, generally have a worse prognosis than young or healthy patients. Pneumonia in patients without risk factors can be treated on an outpatient basis and has a good prognosis. The mortality rate is less than 2%. If inpatient treatment is necessary, the mortality rate is given as 2 to 10%. The figures are subject to considerable fluctuations, as hospital admissions are often associated with serious pre-existing diseases or advanced age, which in themselves lead to increased mortality. It is interesting to note that the mortality rate for pneumococcal pneumonia treated on an inpatient basis is particularly high and is still 20% today. In severe forms of pneumonia, which always have to be treated in hospital, around 20 to 50% of all patients die. The so-called nosocomial pneumonia, which is acquired in hospital, generally has a much worse prognosis than community-acquired infections due to the stubborn pathogens. Many of the pathogens that cause the disease have developed so-called resistance over time, so that treatment with certain antibiotics is no longer effective against them. In many cases, the medication used is then unable to destroy the pathogen and/or prevent it from spreading further in the body. The reason for such resistance is the more frequent use of antibiotics in hospitals. 2/3 of hospital-acquired infections that are fatal are pneumonia. Overall, it is estimated that around 40,000 to 50,000 deaths are caused by severe pneumonia in Germany every year. The number of pneumonia cases increases even further during periods of severe flu. As a result of influenza, pneumonia can develop, especially in patients with weakened immune systems. Pneumonia prevention, vaccination against pneumococci. The Standing Committee on Vaccination, STIKO, at the Robert Koch Institute recommends vaccination against pneumococci, the most common pathogens that cause bacterial pneumonia in old age, for all people over the age of 60. The one-time vaccination should be a polysaccharide vaccine that contains 23 antigens from different types of pneumococci, which are responsible for 90% of the disease. The STIKO also recommends vaccination against pneumococci for all children from the age of 2 months. The 4 vaccinations against pneumococci are usually administered in parallel with the combination vaccination against diphtheria, tetanus, whooping cough, polio, hepatitis B, and Haemophilus influenza type B, HIB, i.e. the infant should ideally be fully immunized against pneumococci by the age of 11 to 14 months. A conjugate vaccine is available for this basic immunization, which is tailored to the immature immune system of infants and young children, and which protects against 13 and 10 of the most dangerous and common types of pneumococcus, respectively. For children, adolescents, and adults with an increased health risk, e.g. with congenital or acquired immune deficiencies or immunosuppression, including a missing or non-functional spleen, asplenia, chronic diseases such as asthma or diabetes, kidney or heart diseases, after a bone marrow transplant, and before, or at the latest after, the use of a cochlear implant, a pneumococcal vaccination is also recommended in order to protect these high-risk patients from pneumococcal diseases such as pneumonia or meningitis. The vaccination protection begins approximately 3 weeks after the vaccination. People with ongoing health risks can receive the polysaccharide vaccine from the age of 5. For children who have previously been vaccinated with conjugate vaccine, as recommended, the minimum interval between vaccinations with polysaccharide vaccine should be 2 months. For adults, a single injection is usually sufficient. For certain risk groups, such as people with immune deficiencies or chronic kidney disease, a booster of the pneumococcal vaccination every 6 years may be advisable. The treating doctor decides whether a repeat vaccination is necessary, depending on the age and the underlying disease. The costs of the pneumococcal vaccination, in accordance with the STIKO recommendation, are covered by the health insurance companies for patients with statutory health insurance. Vaccination against influenza viruses. You can protect yourself against the pathogens of flu, influenza viruses, which usually cause illness in the cold season, by getting vaccinated annually. As a result of flu, influenza, pneumonia can develop, especially in patients with weakened immune systems. 80% of these pneumonias are caused by an additional bacterial infection, e.g. with pneumococci. General preventive tips. In general, the respiratory tract can be protected by the following measures. Don't smoke. Optimize the indoor climate. Intake of vitamin C, vegetables, fruit. Enough exercise in the fresh air.